think in its simplest form, what this trial is trying to accomplish is trying to identify the unique features in a patient's tumor that may predict that they are more likely to benefit from immunotherapy, and then subsequently get them that treatment in advance of their surgical therapy. And this is really one of the first trials that aims to use a biomarker, something that we can identify in the tumor to help us identify those patients most likely to benefit from immunotherapy treatment. One of the things that's important to emphasize is that the MammaPrint assay is what we consider to be an integral biomarker for this trial, meaning that we utilize this test to determine whether or not patients are eligible for treatment. That, in addition to the fact that patients must have stage 2 or 3 hormone receptor positive, HER2 negative breast cancer. And if they are MammaPrint high 2, they are then eligible to be randomized on this clinical trial between standard of care chemotherapy in advance of surgery. And that chemotherapy is adriamycin, Cytoxan, and Taxol, so the standard ACT regimen, versus the experimental part of the protocol, which is that ACT chemotherapy regimen in addition to Durvalumab, the immuno-oncology agent. The primary objective will be invasive disease-free survival. So our primary goal is to understand, does administering an immune-oncology drug in addition to standard chemotherapy decrease the likelihood that a patient will ultimately have a recurrence of their breast cancer? However, I think a secondary aim that is really going to be of importance is we are going to be measuring the rate of pathologic complete response at surgery. It will be very interesting to see if this study, adding an immune-oncology drug to standard of care chemotherapy, may improve those rates of pathologic complete response in this disease entity. Many patients with early stage hormone positive, HER2 negative breast cancer undergo surgery as the initial treatment for their breast cancer. The idea of administering systemic therapy in advance of surgery, while we do it for some patients with more advanced disease, has not actually been the traditional paradigm of treatment for this cancer type.
What this trial is going to do is extend that into the estrogen receptor positive, HER2 negative space, and beg the question of those patients who have higher risk estrogen receptor positive, HER2 negative, but MammaPrint 2 or high risk by MammaPrint molecular score, those patients may benefit greatly from immune-oncology agents added on to neoadjuvant chemotherapy. So what's going to really drive how this trial, we hope in future changes practice, is to see the impact of changing the way we approach these high-risk ER-positive cancers.
So we can completely understand why patients would be wary of receiving systemic therapy in advance of their surgery. The gut instinct is to feel that when they're diagnosed with a new cancer, they would feel more at ease if the cancer was out immediately. However, we have actually done numerous studies helping us understand that for women who need chemotherapy treatment for their breast cancer, whether that chemotherapy is administered in advance of surgery or after surgery, their clinical outcomes are identical, meaning that the chances that the cancer could come back at some point in the future are identical. Their likelihood of survival from breast cancer is identical. And I think what makes the idea of administering the systemic therapy in advance of surgery so exciting is the notion that if we could identify a subset of patients who respond so well to that systemic therapy up front, maybe they don't need as much systemic therapy after surgery and could avoid overtreatment. Conversely, if individuals may have greater disease burden still present at time of surgery, maybe those are the individuals that actually need more tailored therapy or escalated therapy after surgery. That is not the paradigm yet in hormone receptor positive breast cancer, but I think studies like this are needed in order to understand whether or not translation of that paradigm is possible.
I think there are two other elements we need to consider. The first is from a patient's perspective, that if you can be receiving a drug that you would be receiving anyway, but you can have the privilege to see the cancer melt, reduce in size, become less obvious, perhaps even impalpable in your breast. That is the most awesome test of an individual's cancer responding to her treatment. From a surgeon's, and from a very selfish surgeon's perspective, to know that we then have options, perhaps of doing breast conservation rather than mastectomy, to know that we can potentially do less surgery to the axilla, the privilege of having those additional choices as a consequence of neoadjuvant therapy really makes this whole concept of targeting cancers with powerful drugs ahead of surgery very attractive, both from a patient and from a surgeon perspective.
So we recognize that the surgical team may be the ones first interfacing with the patients who are indeed eligible for this trial. We would encourage good communication between the surgeons and the medical oncologists so that if patients may be eligible, the entire care team can facilitate determining the best way to determine whether or not that patient is indeed MammaPrint high 2 status.
I would like to think that as surgeons, we've become much more adaptable to accepting that drug treatment and radiation treatment works in partnership with us. I think one of the privileges we have is to be living in a time and in an age where we can materially see the influence of changes in practice, which are enhancing patient well-being. But it's a wonderful time, and this trial is absolutely the sort of trial we need to be doing.